Sir, good evening, sir. This is Nagaraju from Sikla team, sir. I heartily welcome all the panel members for today's scientific meet on MRIs in heart failure. And I would like to introduce today our moderator, Dr. Baksr Naidu, sir, Senior Interventional Cardiologist and Academic Director of Ramesh Cardiac and Multi-Specialty Hospital, Vijayawada. So without any further delay, I will hand over the session to Dr. Baksr Naidu, sir.
Good evening. Thank you so much. Good evening, all our colleagues. I am Dr. Naidu from Ramesh Hospital. Panel members, I could see. Can I? Manoj Kumar, hello. Hi. Hello. Am I audible? No.
Sir, you are audible, sir.
Yes, sir. Yes, sir.
Good evening, Manoj Kumar and others in the today's. Actually, this is not a discussion, it is sharing our views. This molecule, I know when I was a medico, when it came to the market as aldactone, our physiology professor used to speak hours together about this drug, aldosterone, glomerulonephritis, etc., etc. The purpose of this today's topic is what is the role of MRAs in our clinical practice? It's confined to heart failure only, or what subsets of heart failure the patients will get benefit? Is it also indicated in some other clinical conditions? The incidence of heart failure, it is gaining momentum. According to our Srinath Reddy of All India Institute, by 2030, India will be the museum of all heart failures. Because right now, patients are getting admitted in hospital. They are now no longer dying of heart arrhythmias. We are treating the arrhythmias properly, but they are coming with signs of heart failure. Heart failure gets heart failure. Once you treated the patient, if he takes medicines for 3 months, and after 3 months, he will not see us, he will stop the medication. So we will come with the frank heart failure, volume overload. So this is the problem. The incidence is maximum because of 130 crores of Indians, 1% means it's enormous. So some years later, every ward will be full of heart failures. When I was a MD student, I used to take care of female ward. Those days, this is about 1977-80. The wards were full of iron deficiency anemia with failure and rheumatic heart disease, mitral stenosis, heart failure, atrial fibrillation, CV, etc. Now the scenario is totally different. Most of the patients, at least 50% of patients are either dilated cardiomyopathy or ischemic cardiomyopathy, because my professor used to say, a menstruating girl will not get heart attack. Actually, she will give the heart attack to the opposite sex. That's what he means. Now, I know people undergoing hysterectomy as early as 25 years, 30 years. Once they lose this uterus, so they are more prone for heart diseases. So there is silent infarctions, unknown infarctions in female group. So this group is very difficult to address because they will not come to our hospital. Finally, they will land with signs of heart failure. So this is the problem now. So today we want to share our knowledge. What is the recommendation of this drug? So first, there are a few questions here. Actually, it's a questionnaire and sharing the answers. Not one fellow questioning, others are answering. It is just a mutual sharing of our knowledge. So, Krishna Kishore,
yes,
do you
sir.
hear me?
Yes, sir, I'm there.
How are you?
Fine, sir. Fine, sir.
So, to begin our evening
Fine,
topic, Krishna Kishore. So, the first question is, how many percentage of heart failure patients in stage 2, 3, 4? Okay. How many percentage
NIH is stage 2. Normally, most of the patients, slight limitation, around 40% of the patients come to us with stage 2, sir.
Okay.
Stage 3, or 25%, and rest of the patients with stage 4.
No, the year is not the question of how many patients. Stage 2, 3, stage 2, 100% will come to you? No.
No, sir. No, sir.
Stage 1, most of the patients will not see us, right?
No, sir. Stage 1, no limitation of physical activity, no, sir.
That's why they don't come to us. That's what
They
you
don't
mean to
come.
say. So stage
Yes,
4
sir.
anyway, he has to come. He is forced to get admitted, right?
Yes, sir. Yes, sir.
So,
Symptoms at rest.
okay. Our problem right now is, just now I told you, how many patients are undiagnosed in India, Indian perspective. Why? What is the subject and why? Do you have any answer for this?
Initially, most of the patient doesn't know that it is a heart failure, sir, because in stage 2, most of the patients have easy fatigability, muscle pains, mild slight pedal edema.
And they think it is general weakness and they will go to
General
RMPs.
weakness.
They will
They
give
always check their
Neurobion and
hemoglobin levels. They always check their hemoglobin levels, thyroid levels,
they will
rather than evaluating for heart failure.
Yeah.
So,
they will not come to us definitely unless the RMP brings the patient to us. These patients, they do not come to us because they don't know that it's heart disease. So
yes, sir. Present scenario is only RMP.
probably illiteracy, poverty, or RMP dominance. I don't know. But my experience is when I prescribe a medicine, the patient will take for 3 months and he will stop abruptly based on the opinion of his RMP. So then he will
Yes,
come sometime.
And most of the patients are misdiagnosed as bronchial asthma, and they will be on bronchodilators for quite a long time.
Yeah, excellent, sir. Excellent. Really, this is my experience also. Unnecessarily, the patients are on bronchodilators and aminophylline. You know, aminophylline will increase the heart rate. So, worsening the condition.
Yes, sir. It will increase heart rate.
Yeah. Nice answer, Dr. Kishore. One more question is, suppose you think a patient in heart failure, in your setup, what are the basic investigations you do? In your setup, we are not speaking about theory here. In a practice, let us confine to our practice.
Basic things, normal routine blood test like complete blood picture, sir.
That will tell you whether there are underlying iron deficiency also.
Normal routine blood test like.
Yeah, carry on, Kishore.
Yes, sir. To rule out anemia.
Yeah, number 1, because anemia can be there with the normal hemoglobin.
Yes, sir.
You have to do the iron profile. Most of the patients will not undergo iron profile. Am I sure?
Yes, sir.
Total iron binding capacity, TSAT, they will not undergo. They think they are 10 grams, so it doesn't matter. But they will feel weak. Yeah, that is number 1. Excellent suggestion. CBP. Number 2?
Number 2, chest X-ray, sir.
Yeah, naturally.
Number 3, ECG. And if echo is available, we can go for echo also, sir.
Yeah, echo is mandatory, Dr. Kishore. If the patient, you think heart failure, without echo, we cannot treat. I'm not speaking about our practice, but this is a recommendation. Because heart failure is divided into 3, you know it. FREF,
yes.
FMF, and FPEF. Heart failure with reduced ejection fraction. Heart failure with mid-range ejection fraction. Heart failure with pressure, that is heart dysfunction. So generally, I wish you should send all your patients for echo in the sense, or we'll advise our physician to at least they should have one echo.
Chest X-ray also is the basic investigation. Chest X-ray also you can rule out cardiomegaly.
No, that's okay. That's after this coming to CBP, ECG, X-ray. 4th is echo. Echo is mandatory in making a diagnosis of heart failure. That's what I've been interested. That's what you are telling us, right?
Yes.
But in a teaching institution like us, we advise 2 more investigations. Dr. Srinath. One more question to you is, that is question you might have seen this. What percent of patients to use MRIs for heart failure management? This is the question is, I will just change this. Heart failure means here, heart failure with reduced ejection fraction. EF less than 35%. Yes, with volume overload or no volume overload. Clinically, we are assessing a patient. Patient is okay, but EF is less than 35%. So, what percent use MRS in this scenario?
Most of the patients.
Okay, almost this is almost 100% patients. A combination of a MRA plus a loop diuretic. That is what we practice in our hospital. Most of the people less than 35%, invariably they will have some disability. Yeah, that's nice. Nice advice, Dr. Trinath. So nice.
Thank you.
So now the other question, Sikandar Mohan.
Sir, good evening, sir.
Good evening, Dr. Sikandar Saab. How are you?
Fine, sir. Fine.
So there is one more. Did you see that question number 5? This is a very important question because when we see a patient of heart failure, patient will be on so many drugs, so many doctors, including RMPs, this drug, the confusion will be there. Confusion on the part of the patient, confusion on the part of the doctor also, what to choose, what not to choose. So the question here to you is, what is your first drug in when the patient reduced his fraction? What is the first drug generally right now?
When the patient is diuretics, I use diuretic.
Yeah, because the unload the ventricles, preload, afterload, you have to do some diuretic. Number 1,
Yeah.
Agreed. Okay. Number 2.
Then I'll go for ACR ARBs for ventricular remodeling, sir.
Yeah, which do you prefer, AC inhibitors or ARBs in this scenario?
AC inhibitors.
Yeah, excellent. Because that most of the studies say that ARBs are better. Pairing diuretic with AC inhibitor, the problem of hyperkalemia, this will. So that we should take care, right?
Yes, sir.
So some diuretic and AC inhibitors. Suppose you want to start a beta blocker, what do you start?
Metoprolol.
What is the dose you start when the patient got EF of less than 35%?
25, sir.
25, start with the 12.5 milligrams twice daily too. The idea here is to reduce the heart rate to 60 beats per minute.
Yes, sir.
So our AC inhibitions also, they reduce the systolic blood pressure to 100 to 120. So the answer to this is the answer of our Sikandar Mohan is, so the first drug is always a diuretic. Next one of the AC inhibitors ARBs, but evidence says it's AC inhibitor, either enalapril or ramipril, doesn't matter, in the tolerated doses. Some beta blocker, preferably metoprolol, that metoprolol got a lot of evidence. It prevents arrhythmias. The idea is to bring down the heart rate in heart failure patient to 60 beats per minute. And 60 beats, the diastole will be slightly high, so there will be coronary filling. Yeah, nice, Sikandar Mohan. Excellent. Thank you.
Thank you, sir.
One question to you, Dr. Sikandar Mohan.
Yes.
Here the question is coming to the point. What is your experience with the spironolactone? How long you are using this drug in your practice?
Sir, for heart failures and even for cirrhosis of liver, I'm using since 10 years like that.
Okay. So in cirrhosis liver, heart failure, there is a secondary aldosteronism. So you want to take care of this, you are using spironolactone. So what is the dose you start with spironolactone generally? Is it a single dose or BD dose or what is the dose, sir?
Usually I start with BD dose, sir.
25 BD.
Yeah, 25 BD.
What is the maximum dose you have used in your practice?
Maximum, 100 per day.
100 BD, you can go up to 100 BD. Yes. But generally, in our practice, I used to limit to 50 milligrams BD. Yeah, you can go up to BD. But what percent of people you have stopped the drug because of gynecomastia? That is the problem here.
Yeah. Actually, in cirrhosis of liver like that, already.
That is not the only heart failure. I am speaking about heart failure now with the normal level, normal kidneys.
In heart failure, I have seen nearly some 10 to 20% of cases like that, sir.
Yeah. What is the plan there now?
Yes, sir.
No, what do you advise? Did you stop the drug or you have any treatment for that? Any plan for that?
For painful cases.
Getting the dividing of the benefits of the drug.
Yeah. Actually, if he's having a painful gynecomastia, I am stopping the drug, sir.
Okay. Generally, if the size of the breast is small and the patient can tolerate, I will tell them to tolerate it because the drug is working well.
Okay, sir. Okay.
Because the pain means the drug is working well, there is some sodium retention. That if the patients cannot tolerate only, generally in my practice, I will stop this drug.
Okay,
or I will reduce the drug. If the patient is painful also, you can go with a small painkillers. But anyway, that is the body language of the patient at the given time. You are the best person to decide. The patient is not interested, he will be telling, sir, this drug is not working, please, sir. If the patient is convinced, we can go with this way. Reduce the dose or some painkiller, convince it, or we can stop it. Okay. But in our practice, generally, we are not using spironolactone. We are using nowadays epinephrine.
Okay.
So, what is your experience with epinephrine?
Actually, I have somewhat little experience with epinephrine. Sorry, I was using spironolactone only.
Anything, you know, why do you prefer, why do you love spironolactone to epinephrine?
Actually, I know that epinephrine is having a little more, less side effects than spironolactone, sir. Like painful gynecomastia like that. But because of the cost.
Yeah, so the cost factor, and because you have so much experience with spironolactone, that is the thing your pen is going towards spironolactone, right?
Yes, sir.
But you know, there is some evidence to say epinephrine is slightly better than aldactone. There is a study known as, I will tell 1 minute, I will take your time. This only for the benefit of our listeners.
It's a real study. Real study. It's a real study.
Real is one thing, but it is when the patient gets admitted with Phillips class 2, 3, 4. Suppose he survives from Phillips class. So the EPISA study shows that epinephrine is slightly better if you start within 7 days. Drastic reduction in mortality by 31%, all-cause mortality, and reduction of sudden cardiac death by 34%. You are speaking about, I am speaking about acute MI situation. So here people say epinephrine is better than aldactone, but my experience during MI stage, aldactone may be better than epinephrine because aldactone, as you said, somebody said the negative remodeling, aldactone enhances positive remodeling. This hardens the muscle, damaged muscle tissue. It makes the muscle not to enlarge. So there will not be global dilatation of sometime if the patient is on aldactone for the first 6 months of post-MI status. So that is the thing. Anyway, the cost factor, all patients, all doctors were worried of the cost factor because he may take the drug for 1 week, but because of money, he may not use it. So our purpose is not served. The patient should convince the patient, and you should with the complaints of the patient, you should take it regularly. That is the purpose of this. Anyway, nice Sikandar Mohan. Yeah.
Thank you, sir.
Thank you so much. Thank you so much. So, the seventh question, we came to seventh question. Here, already we described it. Dr. Durga Prasad is there? Dr. Durga Prasad. Hello? In pair. I know, sir. Immediately. Durga Prasad. Hello? Am I audible?
Yes, sir, audible, sir. Just 1 second, sir. Durga Prasad sir is there, sir, in the meeting only. Just 1 second.
Okay. Yes, sir. Dr. Manoj Kumar.
Hello.
Dr. Manoj Kumar.
Sir.
Hi. Hello. Dr. Manoj, there are 2 questions to you. We want to, in fact, 2 questions we want to learn from you. What percent of heart failure patients on MRA develop hyperkalemia? In your practice, this is only not a theoretical, we are speaking about just our practice, Manoj.
Yes, sir.
How are you?
Yeah, fine, sir, fine. So, coming to the meningococcus MRA and hyperkalemia, even though we know MRA decreases improves the mortality and morbidity in heart failure, the basic concern for starting is hyperkalemia. What is very much emphasized in our whenever we were studying or whenever we went through all this post graduation or undergraduation, everywhere, whenever we are taught about MRA, the first and foremost complication is hyperkalemia. And we are also tuned to so much that we are worried about hyperkalemia whenever we are going to start MRA. And after these questions I just went through, exactly is it really problematic? So, and my practical experience also. So basically, whenever we are speaking about MRA and hyperkalemia, in a trials, whatever they tell, the trials in the they show like your rails or FSS and all these trials, the incidence of hyperkalemia with MRA is a whenever, for example, well, let us say 4.5, you say 4.5, it may be going to some 4.8 or 4.5. So according to the studies, they define hyperkalemia as anything baseline in a study baseline that is going more than that, they define as hyperkalemia. But really speaking, nowhere their levels are so high that they need treatment or discontinuation of the treatment. That is one thing. And practical point, actually, what I see is most of our patients, when we, even though we advise them to check their potassium levels after starting melanocortin receptors, most of the patients may not turn out in the time whatever we ask them to come, 2 weeks or 4 weeks. They come whenever they remember, and then suddenly, then we check. It may be still everything is going well. So I don't think hyperkalemia is a major problem with all our MRA patients. And MRA, actually, their calculation, the true instance of MRA calculation, there is a calculation to find out what is hyperkalemia related to MRA. So MRA hyperkalemia minus MRA placebo hyperkalemia by MRA hyperkalemia. So it is roughly 54% only. Other things is because of the placebo effect of the other variables for treatment of heart failure. So basically, all MRAs, whenever there is hyperkalemia, one thing what we can see is there any other factors which are leading to, as Krishna Kishore also told, like diet rich in potassium or taking some other drugs which may increase, like beta blockers or digoxin or any heparins.
AC inhibitors.
AC inhibitors, yeah. And underlying renal failure and diabetes and elderly age group. These are the subset of people who develop more of hyperkalemia. And when, for example, in some of the trials, when they stop the treatment for hyperkalemia, the benefit whatever they had for stopping is less when compared to continuing that. So the outcome measures are decreasing. So patient may have increased mortality and morbidity because of cardiac failure rather than hyperkalemia. But the comparison between stopping the MRA and continuing MRA, actually the benefit is more with continuing MRA. So I think we have to modify the doses, or you have to see other factors which may influence the MRA. And one thing is the pre-treatment level of potassium before starting MRA, more than 4.5 is one of the risk factors for development of hyperkalemia. That's what is shown in the studies. So most of our patients may not be having anything like there is somewhere 3.5 and 4.5. Where comfortable we can start with MRA. And other one is recently there is a study showing SGLT2, especially dapagliflozin, also reduces hyperkalemia. So anyhow, in the in the cardiac failure rate, residual ejection fraction, and all these studies, we are nowadays starting SGLT2 receptor. So blockers. So SGLT2 receptor blockers are diuretic, whatever you advised. Baksr Naidu sir had already told, adding a little bit of diuretic also can reduce whatever the hyperkalemia we deal with in a MRA receptor agonist. So whenever we talk of MRA, we should always think whether it is clinically significant MRA or there is a only value and there is no much problem with the patient, as patient is also fine and there is no much EC changes. I think we can still continue with MRA. There is no point in discontinuation. And the percentage of patients which can be stopped MRA, I don't think we are stopping all the MRAs. Either we can come down with the dose or increase a small dose of a loop diuretic.
Yeah, that is over.
Yes, sir.
That is very fine, Manoj Kumar. You want to say that you need not worry about hyperkalemia at all.
Yes,
if
sir.
you take some little extra care, this problem can be solved. Because the benefits of MRAs they should not be deprived of because of this 4.5, 5.1. So you did not stop the drug. That's what you are advising. So in my experience, so far I am practicing from 1980 onwards. I stopped in 1 or 2 patients where the potassium level crosses 6. Most of the times we can manage it with some diet modification or addition of some other drug. Or in our practice, ACE inhibitors along with MRAs. So let us take some extra care. Otherwise, we need not worry about this. The book says that 10%. I don't think it is 10%. Yeah, nice discussion, Dr. Manoj.
Even epinephrine is better than spironolactone. When even the percentage of MRA, the increase of potassium is less with the epinephrine, sir.
Yeah. Nice. Next question is to our Nirmal Kumar. Is there? Dr. Nirmal Kumar? Nirmal Kumar.
Sir, Nirmal Kumar sir actually
Not
disconnected, sir. Disconnected.
That doesn't matter. Doesn't matter. We discussed about this MRAs already. We need not worry about that. Now, Vardhan is there? Dr. Vardhan.
Sir, Nirmal Kumar sir has joined, sir.
Okay. Is there? Dr. Nirmal Kumar? Not there. Do you hear me?
Yes, sir. Good afternoon.
Nirmal Kumar. Yeah.
Good afternoon, sir.
Sir, good evening. Thanks for joining. So, there is I think you are following the discussion. There is a question for you. Not question, there is only some clearing out doubts, everybody doubts. So, in your practice in heart failure, which drug you start and what are the doses? You can tell us in your practice, based on your practice. If you start aldactone, what is the dose and when do you reduce it?
We start AC inhibitors and beta blockers and I
Already the patient is on AC inhibitors and beta blockers. So we assume that the patient is on AC inhibitors and beta blockers.
Sir?
Yeah.
Along with the antiplatelet, cyclosporine, clopidogrel, sir.
Okay.
Statins, including that.
No. What is the dose? No, we have two drugs right now for MRAs, spironolactone, eplenolone. Which drug you start based on your experience? What is the dose? The initial dose and how early you escalate the dose? What are the parameters based on which you will stop the dose or stop the drug or reduce the dose or increase the dose?
Sir.
It is not clear. Probably some technical error. Hello?
Hello, sir.
Yeah, please, Nirmal. This is the question. No, there is a display there.
Sir, Nirmal sir, just I require your request to switch on your camera, sir. Just I will take one screenshot, sir.
Me?
Nirmal sir.
Yes, 1 minute.
Is there? Hello?
Sir.
Yeah.